Thank you very much. Good morning, ladies and gentlemen, dear colleagues. As you know, SPECT changed dramatically our imaging with increasing the sensitivity, but SPECT CT actually was a revolutionary change in nuclear medicine with increasing the specificity and also in some specific cases sensitivity of our test. Why? Because it's a combination of form and a function. You can localize any hotspot which you see in your planar scan and SPECT precisely with the help of SPECT CT. You can perform attenuation correction, scatter correction with CT part of your SPECT CT, and also there's an ability to calibrate the SPECT images in absolute units of radioactivity to something like SUV in PET scan. Let me start with the utility of a SPECT CT in oncology. And first with thyroid imaging. Yesterday we talked a lot about thyroid cancer, and now I'm going to show you the utility of a SPECT CT in thyroid cancer imaging. There is a growing number of studies confirm that radioiodine SPECT CT is a powerful diagnostic tool overcoming many limitations encountered with planar imaging interpretation, and SPECT CT reduces the equivocal findings frequently reported on planar imaging and also clarifies the interpretation of planar images. It means you will have less false positive findings. There are some publications. I am going to show you some of them. For example, in this publication, they evaluated the patients with suspected bone metastases, and they showed that SPECT CT had a sensitivity of 93% and a specificity of 97%. And also in this publication, they did routinely post-ablation iodine SPECT CT, and they showed the sensitivity was 65% with the SPECT CT and also with planar imaging, but the specificity increased from 55% up to 95% with SPECT CT. Another study from Germany, they did also routinely after iodine ablation SPECT CT with low-risk patients, and they showed that the accuracy of SPECT CT was better than planar imaging in 24% of patients, and the SPECT CT revised the end staging of the patients also in 24% of patients. And interestingly, they showed in their imaging that lymph node metastases occurred in about 26% of patients with T1 tumors and also in 22% of patients with macro carcinoma. It means less than 1 centimeter tumor. Here, one example from this study, SPECT CT after iodine ablation in a 70-year-old patient with PT1 AM tumor. It means multifocal tumors, and they showed here at least 3 lymph node metastases. Here, one example from our clinic, a young female who had operation because of this accumulation in the cervical area, and after 6 months we performed again the radioiodine scan, and the accumulation was still there. Therefore, we performed an SPECT CT, your SPECT CT, to localize the accumulation. After that, we send the patient to our ENT unit for performing an operation under gamma probe. We could find the lymph node. 24 hours later, we performed again SPECT CT for confirming the operation success. Another example, a pre-ablation iodine SPECT CT imaging in a 56-year-old man with a 7.5 centimeter minimally invasive follicular thyroid cancer in the left lobe with vascular and capsular invasion, extrathyroidal extension, and negative surgical margins with central compartment nodal disease. It means PT3, N1A tumor. You see here a faint accumulation in this region, mediastinal region, and in SPECT you see also a hot spot, but with the SPECT CT you can localize this part of accumulation is in the esophagus. It means it is physiologic, but the other part is in the bone, and you find a bone metastasis. Neuroendocrine tumors. I'm going to give a talk tomorrow about radiopeptide therapy of neuroendocrine tumors. But now briefly I show you different radiopharmacological substances which we have for diagnostic and also treatment of neuroendocrine tumor patients. Here, one example, it is an octreotide scintigraphy in a patient with neuroendocrine tumors with unknown origin, lymph node metastasis in the right mandibular angle, and subcutaneous metastasis in the right temple, and also faint focal pulmonary uptake. As you see here, SPECT CT could confirm these accumulations in the lung precisely. And also you can use SPECT CT for the treatment, for the follow-up after a specific treatment in neuroendocrine tumors. Here one example, it is also an octreotide scintigraphy with a SPECT CT of a patient with pancreatic neuroendocrine tumor and liver metastasis. We perform prior to radiopeptide therapy these scans, and after 4 cycles again. And as you see here, a partial response after 4 cycle radiopeptide therapy. Again, you can use SPECT CT for treatment follow-up. Here again, another scan of a patient with also neuroendocrine tumors of the ileum. It's a high neck tuck SPECT, and we did it prior to radioembolization, and 3 months after radioembolization, you see a partial response after radioembolization. I-MIBG scan. It is also one of the best imaging scans, especially for neuroblastoma, pheochromocytoma, and medullary thyroid cancer, and actually has a good sensitivity for the imaging, but with SPECT CT, you can increase your specificity and sensitivity dramatically, because in neuroblastoma patients, especially children, it is important to find all lesions for a right staging of these patients. Here, one example, 60 years old boy with recurrent neuroblastoma. He received first an MRI. MRI was unremarkable. After that, we performed I-MIBG scan, and we could find this focal accumulation in this region. We talked with our radiologists. Retrospectively, they could find also in MRI scan this finding. It was a lymph node metastasis. After that, the patient was operated, and our diagnosis was confirmed. Another example, a 4-year-old patient with a history of stage 4 neuroblastoma. Since 2 years in remission after treatment, he performed this scan as follow-up scan, and actually you can't see any real suspected lesion, but in a SPECT CT you find here one bone metastasis. Also here in sphenoidal bone metastasis in Germany. In the cold time, it's not easy to evaluate this region. A lot of patients show accumulation in the nose region, and in this regard, the patient had a recurrence. Another example, a 2-year-old patient with retrovesical neuroblastoma. Okay, it's not easy to evaluate the retrovesical area. And as you see here in this scan, you can't actually find any suspected accumulation. Here you see the accumulation in the bladder. The tumor was the dorsal part of the bladder in MRI, and in SPECT CT we could evaluate and localize the accumulation in this area. It means we could after that treat the patient with I-MIBG therapy. And it's interestingly, I have to show you here something in this case. The first SPECT CT which we done seemed like this scan. You see a lot accumulation in the bladder and actually no accumulation in the tumor. It is because of the normalization effect in the SPECT CT. We put a Foley catheter, a urinary catheter, and did the SPECT CT again after that, and you see here good accumulation in the tumor. It's very important to reduce the physiologically uptake in the SPECT CT, avoiding these effects with normalization effects. Now, the bone scintigraphy and bone metastases. You know, bone scintigraphy is a very sensitive procedure, but the specificity is not very good. With SPECT CT, you can also increase the specificity of your test. Here some examples regarding bone scintigraphy. A very nice example from Germany. Romer et al. Published this article. In this example, you see the scans of a patient with breast cancer with hot accumulation, hot spots in the spine, in the spine, and you don't know if it is malignant or benign. After a SPECT CT, you find osteochondrosis in C6, C7. But another patient with breast cancer, almost the same scenario, an accumulation in the neck region, and after a SPECT CT, they could find osteolysis in C5. It means with the SPECT CT, you can increase your specificity of the test. There are also a lot of publications regarding this subject, SPECT CT with bone metastases. All of them showed the increasing of specificity and also decreasing of unclear lesion. Also, we published in a European journal our retrospective evaluation of 406 patients, and we could show actually, especially the specificity was better with the SPECT CT, 91% compared to about 75% with whole body scan and SPECT, and also the positive predictive value of the test was better, and it was the case for breast cancer and also for prostate cancer. Another example, a patient with breast cancer showing an indeterminate finding in T6 proved to be a bone metastasis after SPECT CT. And also another patient with breast cancer, an indeterminate finding in L3, as you see here in this scan, and SPECT CT showed degenerative changes in this area. Sentinel lymph node imaging is very interesting imaging and very helpful, and you can perform it for different cancers, especially breast cancer, melanoma, and penis and vulvar cancer, prostatic cancers, and SPECT CT in some of them is very helpful, especially in melanoma of the cup and of the head and neck. And sometimes for breast cancer is very important. I am going to show you some examples here. A patient with melanoma. Here they injected the radioactivity in the planar scan. They could not find any accumulation as sentinel lymph node, but in the SPECT CT you can see here the sentinel lymph node was exactly adjacent to the injection site. Another example with breast cancer, actually for breast cancer is very straightforward thing, and Sentinel scintigraphy is very easy to evaluate, but sometimes you cannot find any accumulation in the axilla also after 24 hours after injection. In some cases, SPECT CT in about 60 to 70% of these cases can be helpful for finding the sentinel lymph nodes. For radioembolization, as I know you do also incubate radioembolization of the liver metastases and tumors, and SPECT CT is very, very important for the treatment planning of a radioembolization for finding the extrahepatic accumulations prior to a radioembolization, and also for evaluation the intrahepatic accumulation. I'm going to show you some examples here. We do first, prior to a radioembolization, a test catheter with technetium MAA scan. We inject the technetium MAA or technetium HSA in the liver for evaluating the lung shunt. You can do it with planar imaging, and also you can perform a SPECT to evaluate the liver, or perhaps you can find some extrahepatic accumulation, but you can increase the sensitivity and especially negative predictive value of your test with the SPECT CT for finding the extrahepatic accumulations dramatically from 32 to 41% with planar and SPECT imaging to up to 100% with SPECT. Which types of extrahepatic accumulation you can find with SPECT CT? You can find extrahepatic accumulation in the gastroduodenal region, like here, in the coil region, the gallbladder, and also in the region of falciform artery, and sometimes in the lung. And some of them are very important, and you have to find them. You have to coil embolize these vessels, which are actually the vessels which goes to these regions. For example, here in 24% of the cases, we can find an extrahepatic accumulation in gastroduodenal region, and prior to the treatment, you have to find these vessels, you have to coil embolize them, and you have to do a re-MAA for proving the success of coil embolization. And as you know, the aim of radioembolization is to treat the complete tumoral area and to avoid as much as possible the delivery of particles in the non-tumoral healthy tissue of the liver for avoiding a so-called radioembolization-induced liver disease. Actually, here I show you one example from a patient with colon carcinoma in FDG PET CT. You see here a lot of metastases with high glucose metabolism, and I show you the MAA scan of this patient, a very good tumoral accentuated accumulation in MAA scan. It's a very good sign for a good treatment response after the radioembolization. The healthy liver tissue shows not a high uptake, and it's very good for the treatment planning. But another case, a patient with metastatic sarcoma, a very big metastasis with FDG PET CT. You see here a high glucose metabolism. We performed the MAA scan, and you see no accumulation in the tumor and just in healthy liver tissue. We did it in 2008, and at that time we didn't have enough data and knowledge about the relevancy of this accumulation, and therefore after that we performed the treatment, and you see here high accumulation in the healthy liver tissue of yttrium-90 in the Bremsstrahlung SPECT CT, and no accumulation in the tumor. It's very important to use SPECT CT for the treatment planning. And also you can do it regarding dosimetry prior to therapy. Dosimetry based on technetium MAA SPECT CT can be used for the selection of patients and for an adoption of treatment planning. It is a publication from Etienne Goran from France. And you can find also with the SPECT CT some parts of the liver which you cannot capture. Here, FDG PET CT of a patient with colorectal cancer, first MAA SPECT CT. Here you show in segment 4 of the liver, no accumulation of technetium MAA. We perform again. And also we perform again the MAA scan, and we could find the vessel of segment 4 and in the second MAA scan, and after that we perform the treatment of the liver. And also you can use a SPECT CT for do a more selective treatment to avoid the radiation of healthy liver tissue with putting your catheter more distally. Here in this case you see just a metastasis in this part of the left liver lobe, but a high accumulation in the whole of the left liver lobe after MAA injection. We perform the MAA again to trying to be more selective, and we could catch the metastasis more selectively, and after that we did the treatment. Bremsstrahlung SPECT CT is also very important after the radioembolization for confirming the treatment. With planar scan, sometimes you can find a very high accumulation in the lung, it's seldom, or an accumulation in the region of hepatic falciform artery, or such accumulations in the intestine. But with the SPECT CT, for predicting GI ulcers is very important. SPECT CT has a sensitivity of 87% and a positive predictive value of 100% in predictive of GI ulcer after radioembolization. I am going to show you some examples here. A 67-year-old patient with colorectal cancer. We did a radioembolization of right liver lobe with 1 gigabecquerel yttrium-90 microspheres. During the radioembolization, the patient did not have any we didn't have any complications, no pain during and until 1 week after radioembolization, but GI complaints 4 weeks after treatment. As you see here, in the SPECT you can't see anything, but in SPECT CT you find this accumulation is not in the liver and is in duodenum, and duodenoscopy showed also radiation-induced duodenal ulcer. Another case, a 75-year-old patient with cholangiocellular carcinoma, whole liver treatment with a total of 600 megabecquerel yttrium-90 microspheres. We didn't have any backflow during radioembolization, but a stasis. The patient had nausea and vomiting during radioembolization, treated with ondansetron, and as you see here in SPECT CT, we could find light accumulation in the stomach, and gastroduodenoscopy showed radiation-induced peripyloric ulcer in antrum. SPECT CT in benign bone diseases. Actually, my colleague is going to speak about orthopedic SPECT CT today afternoon. It is just to warm you up for this session. SPECT, as I said, bone scintigraphy has a very good sensitivity, but the specificity is not very much. You see a lot of accumulation, but often you cannot evaluate this accumulation. For example, for back pain, here one example. You see the patient has a lot changes in the back, but in the SPECT CT you see one accumulation here, which is a fracture of B12, and also the patient had an osteochondrosis in L2 and L3. You can define actually, and you can diagnose very precisely by using a SPECT CT. And also for chronic back pain, you see a lot of patients has degenerative changes in facet joints, but some of these degenerative changes are active in bone scintigraphy. You can find them and localize them with a SPECT CT and also treat them very precisely. And also you can use a SPECT CT, bone SPECT CT for foot, hand, and prosthesis. For coronary artery disease is also important. You have a lot attenuation in women, breast attenuation, in men diaphragm attenuation, and you can reduce these attenuations by using SPECT CT and increase the sensitivity and positive predictive value of your test. However, there are some limitations with SPECT CT. It is important that the SPECT and CT be co-registered precisely, otherwise you have some artifacts because of misregistration. And I'm approaching to end of my presentation. You can use SPECT CT for technetium scintigraphy of the thyroid instead of iodine scintigraphy. You know, for patients with enlarged thyroid, especially in the mediastinal region, iodine 123 scintigraphy is better than technetium scintigraphy, but with the SPECT CT, you can use, instead of iodine scintigraphy, technetium SPECT CT here. One example, 92 years old patient with recurrence paresis and a mass of unknown origin in dorsal region of the thyroid. We performed first technetium SPECT CT. We found no accumulation in this region. Therefore, we could rule out thyroid tissue in this region. After that, we performed a PET CT. You see here, PET CT was positive. The patient received a biopsy. Biopsy revealed a high differentiated polypoid mucoepidermoid carcinoma of trachea. And also here, another example, a patient with a big mass in the lung. He had a thyroid operation, but we were suspected to a thyroid mass. Therefore, we performed a technetium scintigraphy, technetium pertechnetate SPECT CT, and you see here high accumulation in this mass. It means it was a thyroid tissue. The patient after that was operated, and it was the thyroid. Another example for treatment planning and treatment controlling for after radioiodine therapy. Here a very large mass. This is thyroid mass in technetium SPECT CT. It was about 100 milliliter, and we performed the radioiodine treatment for these patients. And you see 1 year later, just 24 milliliter of thyroid, and it means you can control your treatment after radioiodine therapy for decreasing the size of the thyroid. And if you're interested in SPECT CT, there's a book from our group, Clinical Applications of SPECT CT. You can read it also.